There'll be a theme of efficiency running through that 3-year plan, and it will describe the first phases of what we want to achieve with an electronic patient record, particularly cognizant of the pressures that we have in unscheduled care. And also we've got a theatre issue as well in terms of our IT systems. As well as that, there's the integrated care space. We've already discussed that, picked up on that in the meeting already, that we need better sharing of information between health and social care. And then other areas that we can really monopolise more, for a better word, that was the wrong word, Office 365, which is used by the whole workforce, but there's so much more we can achieve with that in terms of getting the workforce to work smarter, digitally, and again, that could have a huge effect on efficiencies and safety and quality. Other specific areas that we're working with Welsh Government colleagues on nationally is how we get away areas such as the maternity system nationally, the critical care system, and the eye care to support our ophthalmology across the region. So they would be 3 specific areas that we'll be discussing in the 3-year plan. And as well as a 3-year plan of actual delivery of specific digital things to support the organisation, there'll be the themes of what governance we need, what we need to do with business change, benefits realisation. So those kind of core components that we have to get right if we're going to benefit from the opportunity of digital moving forward. And I can't leave out the business intelligence aspect of that as well. We've just come to the end of our 3-year business intelligence strategy as was. We're now going to make the next phase of business intelligence a core component of that 3-year plan. And clearly there's strong links between the performance team that sits with Darren and the healthcare systems engineering team that sits in the Chief Operating Officer's office, where we need to bring those resources together and maximise the opportunity of that.
That's exciting. We're covering so much ground. I think it's really, really good that we've introduced this committee. I've got Rena, Jackie, then Darren.
Just a quick one, Chair. All I wanted to say was we had a very useful briefing sessions with Darren's staff in advance, Darren. That's in advance of the first committee, Jean and myself. And I did find, from my perspective, this isn't my forte, I found it very interesting and the opportunities that are available to us. I do understand there's financial issues and obviously benefits, etc. I really do think we could become, feel like a forerunner in Wales in terms of the way in which we're using digital. And I was really encouraged by the enthusiasm and the motivation and the commitment of the staff to moving this whole agenda forward. So just thank you for
that. Jackie.
Just to brief on what you said yourself, Chair, that I think was an excellent decision that we separated the Workforce OD and Digital Committee into 2 separate committees, and that's been demonstrated by the feedback reports today.
So, Darren.
Yeah, I haven't got the answers, Chair. Just a couple of things. I think we're going to have to do more with less going forward, aren't we, as an organisation, globally, not just in this space. And I think this is a great opportunity to bring the digital agenda to life. I know you work hard at that. I think it's the airtime now through the committee. I mean, we need to get alongside that in finance and be as creative as we can be as well. I was struck by the comments around efficiency and productivity releases. We're pretty good at describing those and not, this is broader digital, and they're not always very good at realising those, and that's why we're looking at our investments as well. So I think it's really important. I think there's a few strands for me. One is we've got to keep the lights on, and so business as usual needs to be maintained. We're increasingly reliant on clinical systems, and that needs to be in place. I've been on call a number of times where things have fallen over and they've been put back straight away, but you realise in those moments how important the digital infrastructure is. So I'd like to see, and we'll talk to Matt about this, what's the BAU component to keep the systems running? Then what's that really rich vein of opportunity for efficiency, productivity, real change in how we do things, and how we can use that to redistribute resource. We're not asking for many upfront necessarily, we're doing robust cases, but they're going to watch the cases they progress. Easier said than done, but I think the aspiration is there, and that'll be a good way to approach it.
Yes, thank you, Darren. Of course, that was your advice, Pat, wasn't it, when we looked at this back a few months ago now, affordability versus cost-benefit analysis, really, and being ready for any investment. So It's really good. Keith, please.
Yeah, well, as Jean said, Matt evidenced and the subsequent discussion has fleshed out, the digital and data part of the committee's got off to a flying start. We need to make sure that the research and innovation bit catches up too.
Thank you. And I think as well, Keith, that is one thing that we can make early progress on with Haldar. I think really, so, and I think Richard will attest to that. Yeah, so point well made though, thank you very much. Could I just make one point on clinical coding? I know we've referenced sort of financial issues associated with it, but there are many thousands of clinical codes still outstanding a month after patients have been discharged. And that's a patient safety issue. So can I just make that point and ask you to really think about it? And the whole question of clinical coding is going to come up, the national lens is going to want this. So can I just ask you to think about that? It's a safety issue, really. Thank you. Thank you very much. But Jean, our grateful thanks to the committee, and we ask you to sort of continue the good work you've started. I can let the board know that we have interviewed in respect of the vacancy for the independent member digital IT. There has a submission gone forward to the Cabinet Secretary, but of course it is his decision. So we wait his decision on that. Okay. Thank you very much on that. And in then respect of audit, taking audit round. Nuri has asked me to raise something on audit. We got done that. Okay, thank you very much. So we're moving then on, Hazel, to the Staffing Act. Thank you.
So this paper provides the board with the annual mandatory presentation of the calculated nurse staffing levels in our reportable section 25B wards. This is a legislative process that's been in place since 2016 and we've remained compliant with throughout, in line with the Welsh Government expectation that all health boards in Wales are compliant. The overarching duty of the Nurse Staffing Level Wales Act is to ensure that we have a safe and sustainable workforce and have robust workforce plans, recruitment strategies, structures and processes in place to ensure appropriate nurse staffing levels across our organisation. During this reporting period, there's been a reduction in the number of Section 25B wards which meet the inclusion criteria laid out in the statutory guidance. At the beginning of the reporting period, there was 29 wards, 27 adult and 2 paediatric, which met the inclusion. The reconfiguration of wards within Morriston as part of the service group's continuing surgical redesign has reduced that overall number of 25B reportable wards to 27, 25 adult and 2 paediatric. As part of the surgical redesign, nurse staffing levels in 3 acute surgical Section 25B wards, K, L and R, were recalculated in November, in addition to the biannual calculation processes outlined in May's board paper. In relation to the scrutiny process this year, this has included visits to areas to observe practice, benchmarking against other health boards and reviewing best practice standards, as well as scrutinising the triangulated approach. The scrutiny process also includes HR and finance colleagues, so I'm confident that the scrutiny process around this has been robust and it is a rounded approach. I will stop there and take any questions.
And there's very comprehensive there. Can I just ask if there are any questions or comments? Jackie?
Hi. Yeah, I was just curious about, we have patients obviously waiting beds in some of the wards that come under the legislation. So they're on trolleys in corridors. So first question is, do they come under our consideration at all? Because they would ordinarily be in those beds on those wards. And then my other question is, where we have onboarding, so on one of the wards, or we have an additional patient above the planned numbers, do we recalculate the nurse staffing numbers needed to account for that additionality?
So in terms of the first question, if those beds are within that kind of ward that's in a 25B ward, on a permanent basis, they would be considered in the Nurse Staffing Act calculations. If it's additional patients that are brought in, that's then over and above in terms of professional judgment. So the nurses on a day, because it can change from a day-to-day or a week-to-week basis, these calculations are made at set points during the year. So over and above that, it's much more fluent, because you wouldn't want to wait until the point in time when you were doing the nurse staffing calculations. You'd want to make a kind of a daily, sometimes you know, professional judgment about what's required in terms of safe staffing.
Sarah, Steve.
Just recognising what Hazel has said in terms of it being a legislative requirement, but also safe and sustainable workforce is also important to our staff and health and well-being, and in terms of influencing our culture organisationally too. So not to underestimate that, and to echo the sentiment that Hazel has shared in terms of that robust scrutiny process. Myself and my team are involved in that. So in terms of the wider discussion, and very much a focus on those safe and sustainable services.
Thank you, Sarah. Steve?
No, thank you. Hazel, I think I'm right that this Act doesn't apply to mental health learning disabilities. Is there an equivalent, or is there a plan to extend it, or do we just make up our own levels?
It doesn't currently. There's very specific areas that are in the Act, although there is a wide overarching kind of requirement to ensure that we are making safe, reasonable staffing decisions in all our areas to ensure safe staffing. There was an intention to roll it out over community district nurse and mental health services, which was paused, and there's been a review of the Act. It is likely that there will be an expectation going forward that the principles of the Act are considered more fully in other areas, and mental health would be a priority area.
Thank you.
And Hazel, just to let you know on that, I have asked Steve if the Quality and Safety Committee can take a look at the benefits that were meant to accrue from the introduction of this Act. The benefits included reduction in complaints, claims, pressure sores, HCA and rates, etc. So just want to understand what has actually happened. And I think this is something that we then as chairs are going to have a look at across Wales. So just to be upfront and say, I have asked for that. And particularly if there's any suggestion of this Act being expanded, I think that's really important, just to see the expected benefit, or the expected benefits, have they actually been realised?
It is I think that's really important, because the whole premise of the Act is to ensure that safe and sustainable workforce, and the benefits that brings. There are mechanisms within the Act where we will be able to draw some of that data in terms of measuring the benefits, so that shouldn't be too difficult.
Thank you. That'd be really helpful. Thanks for that. So we do now come to audit. And Nuria's asked me to draw attention to the two alerts that are referenced in the paper that we have. And of course, we have already talked about the financial position in some depth. She's asked me to flag the last meeting of the Audit Committee and bring to the board's attention two limited assurance reports in relation to tertiary services and records management. Nuria advises that she's referred them to the relevant committees under our governance arrangements, but she wants the board to know, and particularly the high number of outstanding audit recommendations, and she wants to seek the board's support to ensure we get back on track.
We there was quite a lot of concern in committee. There was 113 overdue recommendations, which was 30% of all recommendations were overdue. So we were wondering how that looked across Wales. So internal audit, that's in relation to internal audit reports. Internal audit are going to come back with a report on performance across Wales in terms of outstanding recommendations. So we'll have a look at that and see how that goes. But it was a request for that to be covered at board, really, to put the pressure on.
So I'm sure the board would want to support the audit committee there in getting that work back on track. So Hazel, anything you want to add there?
So the head of compliance is running a report for all the execs, and we're going to consider that at our next executive team meeting. Some of them are quite old, so we are encouraging everybody to revisit them with fresh eyes approach in terms of has other actions been happened that mean that they are no longer required, or has the service changed? So we are taking a fresh approach really to trying to close those down. I think another key thing, we're looking at changing the process as well in terms of head of compliance contacting the execs at the time the draft report's available and the actions are, just to test out whether those actions, are smart actions, and also I think we've all been a bit too optimistic, and I'm included in this, in terms of when we can deliver against those actions. So I think we are taking a fresh approach to that. Matt?
Yeah, can I just come in on the records management limited assurance that we've had? I just wanted to make it clear to board members that the audit was applied to records that sit outside of the core health records. So we've had health records, but the core health records audits for the last couple of years where we've had at least reasonable assurance, if not substantial. This is more about other records that sit out in departments which need to be standardised in their management in line with what we do with our core health records. So I just wanted to offer that assurance that this doesn't pertain to the bulk of our records in the organisation. These are other ones that need to have that same management approach as our core health records.
Thank you, Matt. We'll make a record of that. Thank you. We move on then to the Charity Committee, and Nuria's asked me to advise that she wants to assure the board the investment portfolio, according to projections from the investment managers, is sustainable over 5 years and expected to produce an income of 140,000. She wants me to advise the board that we've increased our income by 42,000 and that the new strategy for the charity is bearing fruit and the team's raised £440,000. And at the next meeting, they'll be discussing the financial plan to ensure that the charity can support staffing costs over time. So that's good news. Nicola, is there anything you want to add there?
No, I just want to congratulate the team, to be honest. They've done an incredible role the last couple of months. Their energy in the last meeting was fantastic. The two big projects, the Cut to Close campaign and the Going the Extra Mile. There was a sponsored walk to support the Cut to Close that was postponed last week due to the storm. So that will be, I think, rescheduled for January or February. So it'd be great if any other board members want to take part. I know me and Nuria had signed up for that. So.
Thank you very much. And Darren, do you want to just come in there?
Yeah, just two quick points. Thank you, Chair. One is we're currently going through the audit of the charitable funds accounts for 23-24, and we've submitted the relevant paperwork to Audit Wales, and that work's progressing. I've heard a thing either positive or negative, so I always assume that's positive because we really can't. The other thing was just to reflect on the good work and to echo Nicola's comments. There is good work going on, and Richard and I are working seamlessly to increase the capacity of our flexible funds. The majority of funds, as you know, will be very restricted for specific purposes. We're very respectful of that. But the more resource we can get into a general fund, the more we can start to impact more globally across the board in a more consistent way. So good work at the very start of the journey. Really exciting to see where this goes.
Thank you very much. So let's move on then to the two items that we have before we have our lunch break, both around maternity and neonatal services. So Hazel, I'm going to turn to you first, I know, on 5.3 on Goal Command. Thank you.
So the purpose of the report is to set out the progress discussed as part of the Goal Command arrangements established for scrutiny and assurance of improvement within maternity and neonatal services. In terms of background, in December 2023, the Health Board's maternity and neonatal services were placed by Welsh Government into enhanced monitoring. The escalation status followed an unannounced inspection by Healthcare Inspectorate Wales in September 2023, during which 7 areas of immediate action were identified. A Gold Command structure is in place, led by the Deputy Medical Director as the Senior Responsible Officer, to seek assurance that action is being taken. The main area of focus for the group are enhanced monitoring, inspection action plans, national reports, open incidents and horizon scanning. Progress reported at the most recent Gold Command meeting is set out in the report, but some of the highlights include one outstanding action for enhanced monitoring working Work is ongoing with digital colleagues to populate it using data from existing systems. Gold Command is now given focus to the evidence required to support de-escalation from enhanced monitoring, with the criteria under review by the maternity team. In terms of HIW inspection reports, the two 2019 improvement plans, 2023 immediate improvement plan and 2024 immediate improvement plans are closed. Where actions remain, they are on track with non-overdue. 4 of the actions in the 2024 General Improvement Plan are due to be closed in November 2024, and those ones are on track and will be reported into the next Gold Command meeting, and 1 in December 2024. Work is on course for all but 2 of the recommendations for all improvement plans to be completed by the December 2024 deadline. There are these two are the BFI, the Breastfeeding Initiative training. Staff have been rostered to undertake the training, and this will be completed in January 2025. And the recruitment of 1 woman's experienced midwife will be complete by 2025, and that will be a great addition to the team. One of the milestone achievements has been the reinstatement of community maternity services. Stage 1 was the reopening of the freestanding midwifery unit at Leith Port Talbot Hospital on the 16th of September, followed by home births on the 21st of October. The actions in relation to the HIW reviews, as well as in response to national reports, are progressing well. Sprint sessions have taken place to close incidents as soon as possible where no harm has occurred, while the more serious are investigated by the midwifery teams. A number of the ones open are complex and part legal proceedings. At the end of October 2024, there were 202 open incidents for maternity, of which 130 were overdue, with 19 open for neonates and 6 overdue. 153 new incidents for maternity were reported in October 2024, 97 of these were closed and 183 closed in total that month when taken into account overdue incidents. 19 new incidents were raised for neonatal, 6 of which were closed and 28 were taken into account of those overdue as well. The majority of the overdue incidents are either waiting for completion and sign-off of the incident report forms, and these have been reviewed as part of the regular sprint event, so they could be closed, so they can be closed at the earliest possible convenience. I'll stop there and take any questions.
And just before I open it up, Richard, is there anything you want to add there?
No, I think that's really comprehensive, and I'm grateful to Hazel for doing that and for Raj who's done good hard work with the group to cover this one.
Thank you. Open it up widely then for questions, comments. Pat?
Thanks, Hazel. It was really good to see the progress being made. It gave a lot of assurance. One issue, on the risk report that we looked at in audit, and it's on the papers here, 2 new risks have appeared. Risk 102, inability to maintain birth rate plus compliant rosters, which is assessed as a 16, and 103, high quality choices in birthplace. Community, the risk being the community and intrapartum services remain suspended, again a 16 assessed risk.
So those risks have been reviewed and need to be updated in terms of the next paper that comes here. So the birth rate plus risk was in relation to our critical staffing, which we are successfully maintaining birth rate plus since we took on all the new midwives. But we didn't want to drop it any lower than that at the point in time when we reviewed it last time, just to make sure that we managed the sickness absence, which was quite high in maternity services. I would see that coming down again. And the second one was in relation to the community
high quality choices in birthplace. It's about the intrapartum services.
So that one's under review now because we now have opened the home births as well. So that will come up. That will come off. It's to do with the timing of the paper.
Right. It was just confusing because there were new risks that appeared on the register, and then we couldn't understand the assessment given the assurances we had.
So there were a review of the previous risks which were higher. I think they were split. If you remember, there was one risk and we split it. So that's why they appear as new risks.
Okay. Yeah, so at the risk review panel, we felt that the risk that had previously been at 25 for midwifery staffing levels, it felt it was appropriate to close that one down, but open 2 new ones, as Hazel described, because of the change in circumstances. And they felt that it was too soon to be able to close them down or reduce the risk lower.
But as Hazel said, I think that is the trajectory, it's going to go down again.
Okay, thanks.
And probably go back to being monitored by the service group then, I would have thought.
Okay, any other comments or questions? So there are a number of things in the report that we're asked to acknowledge and to recognise really, and that is, you know, around all the additional work that is going on, and particularly to close the HIW inspection recommendations. So I think, you know, we've progressed this with pace since the summer. So everyone involved in Go Command is to be congratulated for the work they're doing there. And I think we can take assurance as a board that, you know, we are making significant progress. And where we have work still to do, for example, around the outstanding and overdue incidents and the sprint approach, etc., and we are looking at that with pace. Thank you. And as we've indicated as well in relation to the next item you're going to talk us through, Hazel, I think as well when Denise Schaefer is with us, she'll talk as well about the approach to incident management. So at that point, can I hand you over to the next one? Oh, you're going to take it, Hazel, are you? Okay.
I'll provide a quick update then.
Thank you.
So the process remains open, has been widened, so it is inclusive. Letters have all gone out to the families as part of the planned clinical review of cases. 25% of the cases have been completed now. Anticipated that by the end of January, at least 40% of the cases would have been concluded in terms of their review. Engagement work, there's been a new appointment to the oversight panel, Ken Sutton. He brings particular experience. He's involved in the East Kent maternity review, and he'll have a particular oversight of the engagement, family engagement work there as well. Lots of engagement work being done. So the reviews had 250 contacts. And Thrice then have been doing an independent piece of work, having a baby project. And that's 465 contacts, which will feed into this review as well. I think other important update is the confidential psychological support is available as independent of the health board, and Thrice and the engagement team are actively promoting the use of that service by any families who need it. I think those are the main updates I wanted to provide. The end report will be probably due in the summer. I think it depends on a number of factors in terms of how many self-referrals we receive as well. So that's an indicated date at this stage.
Thank you very much, Hazel. And just to add some detail on there, I met with the Children's Commissioner earlier in the week, and Rostio Fuentes asked for a briefing, really, a detailed briefing on how the review is going, and particularly family engagement. So we have sent her a significant amount of material, and she has expressed herself satisfied and welcoming of the breadth of ways in which the independent review is looking to engage with families. So that's good feedback then. So can we take assurance on the work that's happening? And as I've said, Denise Schaefer will be with us in January to talk more to the additional progress that they have made by then. Anne-Louise.
Can I just ask if, following the annual general meeting, where some of the more vocal families attended, I wondered whether there was any feedback from them, whether attending was enough for them, and they were thinking of setting up an independent review of their own, and I wondered what happened there. Possibly that has been circulated and I've been out of the loop, but I just wondered whether there was any update on that.
Abby and I are hopefully meeting with one of the families, if not before Christmas, early in the new year, to progress matters with them, and we are engaged with the other family.
Thank you. It was just important that we didn't let that drop.
And we haven't. Thank you. Shall we adjourn for lunch at that point then, have 30 minutes, and then we'll come back to the remainder of our agenda to talk about.
Yes.
I'm the tag, yeah, Deborah was talking. You know where it's been.
Sorry, so we're about into the last section of our meeting this afternoon, but with as important a set of papers as we've had earlier. And we're going to resume on 5.5. And Hazel, can I ask you to take the board through this paper?
Yeah, so this report covers the risk register as well as covering off the board assurance framework, just to explain that we're in the process of having a reset, and the risk management strategy is presented for consideration and approval that will help us and allow us to have that reset. That will lead us into a board development session in December, where we'll be thinking about the board assurance framework and also a new strategic risk register as well, and underneath that what supports it in terms of operational registers and corporate risk registers as well. So that's here for approval today. In terms of the Health Board Risk Register, I'm not going to go into that in detail because many of the risks we've already covered. We've covered unscheduled care, cancer, access to cancer, and the financial risk as well, which are the highest risks on our risk register, as well as maternity risk we've considered. So that's all I was going to do, just introducing, happy to take questions.
Thank you. Thanks. So what we're being asked to do today now is approve the risk management strategy, because we're going to spend a fair bit of time at the December Development Board on risk appetite, strategic risks linked with strategic objectives, etc., as a complete reset. Is that okay?
Yeah.
Okay. So can I just ask, Pat, would you like to come in?
Yeah, just a comment really. We saw this in an audit committee this month, and we gave some detailed feedback on it. But generally, very supportive of the proposed changes. I think it makes a lot of sense, the role of BAF now compared to the Strategic Risk Register. And I think there'll be a more clear link really between objectives and the risk to delivering them through this approach. So, very supportive of the change in general.
Thank you, Pat. And I know that Nouria's wanted me to add as well the importance of the framework being supported by quality impact assessments. And Pat, I think, had audit committee asked for the detail of those, or will it come to the next thing? We'll go to audit committee. Will you go to the next one? Yeah. Thank you. So do you have any other points or comments for Hazel, recognising that we're about to embark on a major reset of this whole agenda? Okay, so we can take note of where we are with the BAF. We're approving the risk management strategy. We've looked at the risk register a number of times today in different aspects, and we will come back to resetting that as well after December. And then we are content to take assurance of where we are on this agenda currently. Thank you. And Hazel, again, thanks to you and the team for all the work that goes into this. It is a considerable piece of work, as we know. Thank you. And now we come to a really important report on mental health services. There's an overarching paper being produced, because this again is the start of what is going to be a detailed strategic programme of work for the board into 25-26 onwards. So Hazel, I'm going to hand over to you to start on that.
Thank you. So the purpose of the paper is to provide the board with an overview of the current mental health services, including the pressures on the services and the outcomes from internal and external reviews of the service and ongoing plans for modernisation and transformation. Mental Health and Learning Disability Service Group comprises of 3 divisions: Mental Health Division, Secure Services and Recovery Division, and Learning Disabilities. For the purpose of this board paper, learning and disability services have not been included. So a breakdown of the mental health services and facilities across the health board is set out, and I think you'll note it's a broad service. Mental health and substance use disorders are one of the leading causes of poor health in Wales, and COVID-19 and the cost of living crisis have impacted on levels of mental health and ill health in Wales and across the UK. And this is further supported by research from Royal College of Psychiatrists. A 2022-23 report indicates the rates of suspected suicides in residents of Powys Teaching Health Board and our health board were statistically significantly higher than other health boards, and that's an area that we really need to focus on going forward. Some of the examples of the services provided include, at the very front of the pathway, our community-based local primary mental health services. They provide assessment and brief interventions. We've got urgent and emergency access delivered via 111, option 2 or single point of access, with escalation to crisis or home treatment teams, psychiatric liaison or mental health assessment if needed. We've got 5 consultant-led community health teams providing care for patients with moderate to severe mental health conditions, and 4 older persons inpatient wards at Kevin Coyd, and outpatient clinics such as memory clinics, community mental health teams and a care home in Leach. And we've got 2 all-wheels services commissioned by the JCC, a medium secure unit and a mother and baby unit. Currently our adult mental health assessment wards have an average occupancy of 108%, with the best practice suggesting that should be 85%. And we've got unique for the service group is our research, development, innovation, improvement, audit and learning hub, which is the learning arm of the quality and safety governance structures. There's a number of national performance and quality indicators which are reported and reviewed on a regular basis. And there's been continuous improvements demonstrated with our planned care performance exceeded the targets around across the mental health measure. However, further improvement is needed to achieve the outpatient waiting times targets for psychological therapies and for outpatient mental health patients at 10 weeks. In terms of the latter, our performance is low at 43%. All the health boards, it's worth noting, are struggling to meet the waiting list target for psychological therapies, but our performance at 60.8 is slightly below the all-wheels average. There are a number of challenges for the service to manage, with the following being the highest priorities. HIW reports over the course of the last 2 years, there's been a number of announced and unannounced HIW visits to multiple sites and services, and each one has generated action plans which are monitored and progressed within the governance structure. Prevention of deaths report over the last 18 months, we've received 4 prevention of future deaths or Reg 28 notes, with a 5th one issued to another health board for which we provide the prison in reach services. 3 of the 4 have been closed awaiting coroner's feedback, and there are themes from some of these, and it's essential that the care provided is patient-centred and that families are listened to as part of the assessment and treatment process, and that this is culturally embedded in routine clinical practice. And I think that's a big focus in terms of that strategic and transformational work that we want to take forward. In terms of workforce, there are recruitment challenges across mental health services, not just in Swansea Bay, but across Wales and the UK. Particularly around psychiatry, and I think we heard that up earlier. HEIW has launched a strategic mental health workforce plan for health and social care to address some of the current and future workforce shortages, and positive progress has been made locally in regards to medical and nursing recruitment through UK nurse recruitment schemes and recruitment for posts by the Central Resourcing Team. Work is ongoing to develop a future workforce plan, including a skill mix review and considering alternative roles and upskilling existing staff. In terms of estates, a number of issues, previous developments at the Kevin Coyd Hospital have seen modern fit-for-purpose accommodation provided for older people, but the 2 wards for adult care on the site must be re-provided as they're not fit for purpose. Proposals are in the final stages for a new acute adult inpatient facility on the Kevin Coyd site following board approval to acquire land owned by WAST. This will require demolition of some of the existing older buildings to redevelop the site, but the remaining land could potentially be sold to create income to address some of the backlog maintenance work. The other main site for inpatient mental health services is Tonner Hospital, which houses services for older people's mental health and the mother and baby unit, which again has a backlog maintenance cost of just under 5 million. So a prioritised plan is in place to address the backlog maintenance issues and updates, but I think it's fair to say the number of the services are not where we need to be in terms of estates. Next, digital. The majority of the mental health services still relies on paper in the recording of clinical documentation, and the WICA system procured by Welsh Government in 2017 was intended to provide a digital information sharing system. However, for many reasons, including delays in the availability of health functionality, Swansea Bay never established a contract for the system, and the rest of the mental health service don't use it. So over the last 18 months, a number of digital solutions have been implemented, and the use of these systems has had a positive impact on quality and safety and efficiency. So health board leads are working closely with the national programme and the local authority colleagues to ensure we've got the right solutions procured around digital. So some of the recent actions taken to address the challenges that I've just described is ongoing work to address all the identified actions and learning from the HIW reports, prevention of future death reports, patient complaints and incidents via existing governance and governance structures. Support was requested from Welsh Government to implement service redesign and transformation and to ensure alignment with best practice. To facilitate this, the service has been escalated to a level 2 intervention under the escalation procedure. That means it's an area of concern for adult inpatient services. That work is about to start on the 9th of December, and we should have an interim report within six weeks of that work starting. The Chief Exec and the Exec Medical Director have been exploring potential opportunities to bring in external expertise to advise on mental health services, and the ongoing increasing demand for mental health services across Wales presents further challenges and risks for the Health Board. I'll stop there and open up for discussion.
Richard, do you want to add anything there?
Just to add, this obviously builds on the conversation that we had as part of the board development last month, and so board members will be familiar with some of the challenges. It's instructive, isn't it? Our mental health services provide services from children through to frail older people with elderly people with cognitive impairment, alongside adults in the middle with medium and low secure, across a number of different, I was just trying to think then how many hospital sites, across a number of hospital sites that are within our health board area and actually outside. So we completely acknowledge the importance of this piece of work, which seeks to triangulate all these different elements of learning from events, learning from Coroner's Regulation 28s, but also taking an opportunity now, because it feels as though we're at a turning point in terms of making decisions about how we might best provide mental health services, both in terms of the clinical services that we provide, but also the locations on which we provide them. And it's an opportunity to gain some external advice on what a modern 21st century mental health service looks like across all those different areas, from childhood through to old age, and for us to make some decisions then in terms of our medium-term plans about how we might do that for the future.
Thank you, Richard. And Abby, I'm going to ask you then if you can set the broader context for the work that Richard just...
Yeah, and Richard started doing that, and it is a very helpful paper following on from the board discussion in terms of reminding us of the context in which we're operating, and then overview of the adult mental health services that we're providing for our population and for wider populations. I think, as Richard has said, I think this is a really important moment for us to use the work that the NHS executive is going to be doing with us as a service of concern in respect of adult services, but also to use the opportunity of bringing in a kind of board level advisor type role to help us work through what a truly modern mental health service looks like, as you said, Richard, from our children and young people services right through to our older person services and our learning disability services together. And if you think about some of the kind of key population health drivers in here, so we are alongside POWERS at the high end of the spectrum in terms of deaths from suicide, and we know that our substance related deaths are also higher. So the opportunity to take stock and to use this as a way of discovery to inform the development of a detailed mental health and learning disability strategic plan going forward. And Richard's right, as part of that, I know we've got plans in train and we need to make sure we navigate our way through that carefully, but it is an important opportunity to make sure that we're making the right call in terms of decisions about where those services should be located. So we need the modern services based on really strong user engagement, engagement from people with lived experience, and engagement with families and carers as a co-production model moving forward. I'm just thinking about our workforce, so we know we've got gaps in here, and keep up. I'd be really interested in the conversation with the university around some work that I saw, and I tell you about the stuff I saw in Copenhagen, some really interesting work that they were doing there in psychiatry around creating psychological safety for the workforce and for looking at things like compassion fatigue that we might see in some of the workforce. So that again, there'll be a really important dimension to this, which is about how do we get the right workforce, how do we make it somewhere that people want to come to work, and make sure that we've got the sustainability and the safety and the quality that our local population would require. So I'm hoping that by January, the NHS executive work is starting on the 9th of December. So Hazel is going to be our contact point. So the NHS exec team will be joining us then, and we'll be working through that detail. We're hoping that the board level advisor will be on board early in the new year. So Hazel and Darren are helping me with that. We've had a small amount of resource from the NHS executive to enable us to commission that. So that will also dovetail in a really helpful time. The NHS exec work, they're doing it on a 30-day cycle, so they'll come in and do one bit of chunk of the first 30 days, and then we'll have a second where they'll get into more of the detail. I guess the first will be a bit really discovery, getting underneath the data and talking to people. But I was assured that we would start getting insights back within the second of those 30-day cycles, not have to wait to the end after 90 days. So we should get some feedback as part of that process, so we can bring that into the board as we go through Jan.
Thank you very much, Abby. That's a really helpful synopsis. And I am going to propose that the board itself keeps oversight of what is going to be a major strategic programme of work, and that we don't remit it to any particular committee, although a number of committees will have inputs to it. But this is a matter for the board itself, I think. So, Chris, I know that you want to declare an interest.
I do, right.
So we will duly record your interest. But of course, and as we said to Keith and Rena earlier, please feel free to make a contribution to the debate, but not participate in any decision. Keith, please come in.
Yeah, thank you. It's good to hear that the board is going to give mental health services this level of attention. We have been here before. We have had reviews of where the services should be cited and how they should be delivered. I'm optimistic that the outcome will be more positive and shorter term this time round. I'm greatly reassured by the Chair's words about keeping this under regular review from the board. I think that's really important. Of course, some of the most ill people who enter that service end up in the inpatient service. The vast majority are dealt with either in primary care or in the community, but some of the sickest people end up in the inpatient unit. And as the report identifies, the facilities at Kevin Coyd are, the adult wards are, and ward F at Neath Talbot are probably not where, it's not where I would want a relative of mine to be cared for. I guess Kevin Coyd, for example, is in the NHS capital plan, NHS Wales capital plan at some point in that process. And I wonder if there's anything that we can, any way in which, as a result of this review, we can maybe raise the priority of that, because I have sat through previous board meetings where we've looked at the Kevin Coyd site and identified how it might be prioritised, but it never quite gets up that list. And it is the last Victorian asylum left, I think.
Yeah. Want me to respond to that, Jen? Yeah, Keith, you're right. Welsh Government, the Welsh Government official who leads on capital was going to visit. I don't know if he has done yet. It was imminent.
It's week Monday.
There we go. So when we're talking to colleagues in Welsh Government, they'll actually have seen it and experienced it, and certainly from my point of view, that's always really helpful. And Ian Gunny in Welsh Government is always really helpful in terms of understanding. Keith, your point is about making sure we're putting the right proposition forward. So whether it's the existing plan with some additional bits on, because we've already talked about some of the other things like mother and baby units, should that be pulled together? For me, it's about pausing and making sure we're making, not pausing it to throw it into the long grass or kick it in the long grass, but about making sure we're making the right decisions with a kind of a quickly developing revised strategic plan around mental health and learning disabilities, so that we're making the right decisions. I would still hope that whatever our solution is, if it did change, that it's still up there, because Welsh Government will understand that the facility needs to, it is not fit for purpose in terms of the environments in which we are treating patients. So whichever, if we just stick with the existing option with some further enhancements to it, then it's on their radar. I guess for us, we need to be confident ourselves that we are raising it up in terms of how we would prioritise it amongst all the things that we've got to consider, because the hard reality is, what is it, about 450 million for the capital programme for the year. And when, I think the last recce I did with Welsh Government, when we put in the last 10-year plan, was that there was about an ask of about £1 billion a year. So Welsh Government will have to prioritise, and we need to make sure that the focus on mental health doesn't go down the priority list, because we, as you rightly say, we've got some really pretty poor environments in which some of our illicit patients are being treated.
And notwithstanding all the very hard work that the staff do there to try and deliver good services, even though there are quite significant shortages in medical and nursing staff still.
I've got Rena next.
Yeah, thanks, Chair. I'd echo what Keith has said in terms of Kevin Coyd in particular, but Tonner is in a very sad state. I've been there recently. My view is we need to get on with this, and that's my worry of this review, Abby, I'll be honest with you, is that we're going to delay again. And if we get Welsh Government's attention to actually putting it in, the capital in that we need, I think we need to be ready to move. So I don't want delay, because I feel we've been sitting on this for the whole time that I've been on the health board, which is 6 years. The other point I wanted to raise was about staffing. And I know our financial position. I'm very aware of where we are, and that obviously we need to take any opportunities if there are vacancies to use the money to help our deficit. But I'm particularly keen that on the mental health side, we've sort of, in a sense, had the ability to, if you like, get money out of that side because of the vacancies. But that worries me, because obviously then we're running at a level which is probably not appropriate in terms of staff. So I am concerned about it, because obviously I do have some personal experience of this, and I really do worry whether we've got the right level of staffing to deal with the demand that is coming through on that side. Thank you.
Abby, do you want to come back?
Yeah, I'll come to Hazel on the staffing, if I may, and Sarah. It's a real balance, and I absolutely get, Rena, that we don't want to push ourselves further back. My sense is that we're quite a long way off getting the plan anyway. As far as I understand it, we're OBC stage, so we're at quite an advanced stage of development. It's just about making sure, a quick check and balance, that in light of an emerging strategic plan, it is still the right thing to do. So I agree with you. We don't want to see this pushed back years, and we need to make sure it's the right decision, and that if we're sticking with it, we are consolidating some of the other services that you touched upon, services in Tonner and things like that. So it's a careful balance that we need to get right here.
So in terms of staffing, I think you're right. I think we do have significant challenges in staffing, which we need to use this transformation agenda to really think about what do we need in terms of workforce. We have some units, particularly in learning disability, with single registrants on, which is way below the standards we would want to see. So there is a significant bit of transformation work to be done that needs to include staffing. And I think, although talking about the inpatient environment, it's equally important that we look at our community mental health teams and access, and when we listen to some of the experiences of patients and families, it can be quite hard to get into services. There's lots of different services, and some of the criteria is quite exclusive rather than inclusive. So I think we shouldn't underestimate the amount of transformation work that's required here. So the building is really important, but there's a much bigger piece of work around transformation models, what we want a modern mental health and learning disability service to look like. And within that, you're absolutely right, the staffing models we really need to think about what does that look like in the future, now and in the future.
I've got Steve and Jean.
Thanks. So I was going to pick up the point about the Kevin Coyd redevelopment and the OPC. That I think this board approved that 2-3 years ago. But before that, there was a lot of engagement with the local community and the local authorities, etc. So a lot of work was done before this board approved it. So any significant change to that would be going back quite a few steps, I think. When I talk to the service group and management and clinicians, they all say that they think it would be better to have everything in one place. And not because troubled young mothers are the same as 95-year-old gentlemen in terms of their needs, but the sort of people that are going to be giving those services are will feed off each other if they're all in one place. So, in their ideal world, the mother and baby unit at from Tonner and Ward F from Meath would all go up to redevelopment and up the top of the hill there. I was going to pick up on the Clanreed situation. We talked about Tythe Newit having half turned down last week. That service, the low security service, is due to move to JCC. So the medium is already in JCC. The low one is due to go. It was due to go next year. Then I think the year after. So that's something that needs to be considered also. And the community mental health service that we provide, which is very important, as Keith said, and is where most people start, is done in conjunction with the local authorities. They're joint teams, and I don't know how that works. Keith may know better. But it seems to me that having teams that are under two different sets of management must be inefficient. And we saw in a couple of high-profile cases recently where that teamwork didn't work very well. So I think we should be looking at that model also in our redesign.
Thank you, Steve. So I've got Jean, Darren, then Chris. Jean, over to you.
Two things for me. I know we've mentioned it several times, but the adult outpatient waiting list being almost 50% short of target, I think that is something that we have to address because we can't sustain that kind of performance moving forward. The second thing is on digital and data, where we talk about the 2017 contract for the Welsh Clinical Communications Information System. With Swansea Local Authority that is, having signed up to that contract and 300 or more of our staff using it. We've had, over the last 12 months, we've had several situations where new contract and procurement for new contract has reached us late. So I'm a bit concerned about what we're doing on that front. What is the national picture looking like? But then secondly, in terms of utilising data, although we've got the administration system and Signal, etc., for me, this whole area is an area that needs tightening up in terms of knowing what we've got for data and digital operation data management. But obviously, it's got to be an opportunity for research and innovation moving forward. So a couple of things there that span the operational issue, new contract, national level, local level, what's the impact for our staff of 300 who might not have a system come next year to use?
Because we're going to remit this to your committee, obviously. But do you want to come in and talk about that now?
Back on that briefly then. Clearly we are facing a big problem in this space with failings of the CCIS, but also the contract coming to an end that, I think there's a strong argument that National wasn't prepared for that early enough, and hence the Connecting Care programme, which is aiming to ensure that we've got social care and health care for mental health and community systems in place by the time we lose that system, is not on track to doing that. Therefore, we are looking at local/regional mitigation plan to address that. We've got quite a mature worked up plan that we hope to be bringing to board if we have a special board in December, hopefully that we can take that plan forward to address the issues of those 350 staff. Plus there's another 350 staff in the community space as well. We put 350 here because this was a mental health paper only. It's a real issue for us. We do have a strong plan to address that. But yeah, in the wider sense, you're right. There are issues that we need to get right nationally on such things.
So we won't be taking that in December, Matt, because the December board is a single issue board on the money and what we're going to do for the rest of the year. But we'll be coming back to it in January with the digital and data strategy, and if we can remit the specific piece of work back to the committee really to focus on for the rest of us, that would be really helpful. Thank you. So Darren, then Chris, please.
Just a couple of quick points here. So, colleagues may not be aware, but the mental health allocation ring fence specifically for mental health services with the technicalities of finance, we've got a really clear line of sight on protecting resource for mental health. And the review could perhaps test whether that level of resource is appropriate or not. I think I really welcome that. On the workforce side, mental health is spending £1 million a month on variable pay for nursing and non-registered nursing. It's a huge opportunity there to revise workforce model to actually get the right people in. One is the workforce and as well. So it's something we're already challenging ourselves with in terms of recovery, but it's an opportunity strategically as well. And just on the estates and buildings, we've got sight of all the individual component parts. I think there's a reflection we need through this review on what City East and Town Centre provision is as well. The Swansea Wellness Centre currently on pause, but we need to reassess. If the review can help us with that, that'd be really welcome. And then we'll look at the big capital sites as well. The majority of this work is tied up in the Welsh Government Capital Prioritisation Programme, which that's due to report either next week or the week after. So we'll get a sense of their prioritisation, of our prioritisation. I suspect we may need to lobby further when we see the results of that, but I don't know the results.
Thank you, Darren. Chris, please come in.
Yeah, a couple of things I think people have covered. I was going to pick up on some of the community facilities as well and how we look at the pathways in terms of transforming. I think my main comment that people haven't picked up is the difference in health outcomes and inequalities for women in mental health. So there is no low secure provision in Wales. A lot of our patients need to go outside of Wales if we need additional support. I think there's opportunity in when we look at the Women's Health Plan, even though that's not explicit. There's something around violence and domestic abuse and something around perinatal care. But I think it is something important for us to pick up in the Women's Health Plan for this Health Board.
That's a really important point. Karen.
Just wanted to say as well that obviously a lot of this work cuts across our partnerships area, that's GPs and our third sector. And there's already an emotional wellbeing strategy that we're taking a number of elements which will complement the work we're doing as well.
Any more comments on that?
So just what, I mean, we're explicitly not talking about learning disabilities, but can we, at some point, we need to, you know.
Yeah, we'll pick up that specifically. Okay. So where we are now then, clearly from the discussion and from the paper that we've had, we have a major strategic piece of work to do here. The strategic work programme that's going to take us, some years really, but will feature prominently in the 25 to 28 IMTP. By which time we'll understand from the team that comes in from the NHS executive. I'm hoping there's support for the board-level advisor, an expert, to come in and advise us. And then we will come back to the board in January with what is the proposed strategic work plan, process, architecture to really kick this work off early in 2025. So obviously we acknowledge where we are currently, and as Keith has said, we acknowledge the hard work that the staff are doing in environments that are not fit for them to work in or for patients to be cared in. They're doing their very, very best in difficult circumstances, and we thank them for that. And we also acknowledge and appreciate the very serious challenges this service is facing, but hopefully the determination as well that we have as a board to sort it and to use this opportunity to get it right and get the right modern mental health service for our population through from, as Richard said, the whole life course. Children and young people, and we talked a lot about that earlier, right the way through to older age mental health. Is that okay? Does that cover it? Okay, and thank you, and thanks everybody who's been involved in putting this together. So now moving on to a new piece of work we've been engaged in, as you know, from the joint board with Howells Arm on the 17th of October. Hazel, do you want to kickstart us on that?
Yeah, so following the direction from Welsh Government to both health boards, just now to joint committee, the aim of strengthening existing arrangements for planning delivery healthcare across the region. Both boards met in October, keynote speakers, Cabinet Secretary for Health and Social Care, and during that meeting and subsequently after, the purpose for the joint committee and the design principles were developed and are presented here for the board to consider and formally approve I should add that the first meeting of the joint committee is scheduled for the 15th of January.
Thank you, Hazel. Neil Wooding and I will chair the Joint Collaborative Committee as we discussed last time, and the two of us are currently thinking about the independent membership of that committee, because it is an orthodox joint committee of two boards. So it won't be any type of hybrid. It is a joint committee comprising chairs and independent members with a substructure from that chief executive and lower levels. And Abby and I will be discussing that with Neil and Phil in terms of what that substructure looks like. So that the 15th of January will be about looking at the terms of reference. So, excuse me. Looking at the terms of reference, the substructure, the work programme for the remainder of 24-25, which we had a detailed presentation on in October, and then what is going to feature in our joint IMTPs 25-28 for the two boards. So I hope that's okay, and I hope we can approve the work that we did on the 17th of October around the purpose and the design principles. Is that okay? Okay. Thank you very much. And then Hazel, we stick with you, don't we?
Yeah, so this is just the routine corporate governance report that comes to the board just to set out the matters considered in committee board, Welsh Health Circulars, business cycle, common sea register, and the chair's action is just here for the board members to receive.
Thank you. Any comments or points for Hazel? It's our standard governance agenda. Thank you, Hazel. And back to you for the board advisory groups.
Yeah, so this report updates on the meetings following of the Health Board Partnership Forum and Stakeholder Reference Group as well. Stakeholder Reference Group is needing to appoint a chair and a vice chair, and plans are in place to take that forward. And in the interim, the Assistant Director of Communication, Insights and Engagement is chairing that meeting and supporting it going forward.
Can we accelerate the process to actually secure an independent chair and vice chair, please? Because this has been the position in the 6 months I've been here, and this is a really important advisory group for the board. So what is the process now for us actually securing those roles, please, Hazel?
Yeah, so within the paper, it sets out really that they're going to appoint from the regional third sector there, and they've got a plan in place taking that forward. So I think hopefully by the next meeting in January, we'll be able to announce that they have appointed.
Chair, if I may jump in, yes, Hazel's right. So at the last meeting of the stakeholder reference group, everybody agreed that they would actually go back into their sort of different groups and partnerships and identify individuals who might be suitable to both chair and be members of the group. So we're waiting for those nominations now and take on board what you've just said about accelerating that process. So we'll go back to them just to chase them up on that nomination now.
Thank you, Richard. Thank you. So that brings us then to 510. 2 meetings of the board to approve. Firstly, on the 10th of September. The correct record. Thank you. And then on 25th of September. Thank you very much. So Hazel, the action will go.
Yeah, so the first action, we've this work ongoing around that, looking at options available to improve how the public see the board and do it. The second action then is scheduled for March 2025. Third action has been completed, a brief has been sent round. And the fourth action then, that's something that we've marked as ongoing, but I think wondering whether we need to ask the Health and Safety Committee to oversee monitor the Neath Talbot Birthing Centre, because they receive regular reports on maternity. And they can include that then, rather than mark it as ongoing, discharge it to Health and Safety Committee. Are we okay with that? Steve, you okay? Yeah. Next action then, that's completed in part, we will update on governance arrangements around Recovery and Sustainability Board was provided to the November Audit Committee, and a formal report is going to be provided prior to the next meeting. And then the last one then, that's in progress as well.
Thank you.
To be completed by January.
Okay, any comments or questions for Hazel? Thank you very much, and thanks to the team for all the work that's involved in keeping this action log up to date. So then we just have 6.1, just for, or take note of what I've been up to since the last board meeting. Don't plan to go through it in any detail. I haven't had notification of any other business, but is there anything, as I say, is there anything that's occurred to people during the course of the meeting you really want to bring to the board's attention or ask about now, as we all be together for a month or so? Anything come to mind? No, well, we have covered an awful lot of ground today. So our final item then, review of meeting effectiveness. So somehow we've managed to end ahead of time. So, which I wasn't certain at all we would do this morning, given the time we had to devote to the very important items that we've had. Hazel and I are thinking about a way in which we can have an anonymised process to enable people to feedback outside of the board meeting, if people would prefer to do it that way. But is there anything now that people want to say? How's it gone today? Anything you think we spent too long on? We shouldn't have had on the agenda? We could have done things differently? It was a weighty agenda today, which we have to incorporate, I think. How do people find it?
Just go back on your comment about the thinking about an anonymised. Why would we do that if we're maturing as a board?
Very good point, and absolutely agree with that, Jean, but some people may think at the minute they'd rather just put their views in without having to say who they are. And I think it's something, when we come to do the board development, that we'll think about how we manage this. But at the moment, I don't want anyone not to think they can contribute if they're a little bit hesitant about speaking up to say what they think.
I'm a bit concerned that it
Okay.
gives an opaqueness to some governance underpinning.
It's not that the issue wouldn't then come up. It's how we manage the issue, sort of whatever it was, Hazel and I would think about it, how we worked it in to the board effectiveness agenda, but not necessarily citing that particular person at the moment. Okay? just to say, so what I don't want anyone not to contribute, but I want people to contribute at the minute in the way they feel comfortable contributing, as we are developing as a board. Okay?
Just a reflection in terms of board maturity for me.
Yeah, absolutely agree. But I think we have to, everyone has to be comfortable.
Yeah, sure.
Yeah.
Yeah, I was just going to say that having had experience of this, it's always a hard thing to do, isn't it? And when I've been on the Social Care Wales board in the past, I'll talk to Hazel about some of the tools that they use, that made it very time done in the moment, so that people didn't walk away and then forget to put it in. But enabled some of what you were saying, John, that it wasn't quite everyone had to put their hand up and say anything, but it was a hybrid. So I'll talk to Hazel about what they did.
Maybe I'm too long in the tooth.
It was a bit snazzy, so.
Rena, please.
I was just going to say, the only comment I would say that I felt today's, with the 3 A's approach to the committee issues, was helpful, because in some ways it was more consistent, because up to that point, it's up to the chair to decide what ones they wanted to flag, which I think this is a better way of doing it in terms of ensuring we've got the right items, and that in a sense we concentrate on the alert items more than anything else.
Thank you. And Steve has been spearheading this with Hazel. So, and as Steve said earlier, comments back, that would be helpful.
Yeah, I mean, when I chair quality and safety, and I know Pat, when she chairs performance and finance, we actually agree on, after each agenda item, where it should go. Should it go to alert, advise, or assure? And so the independent members are all agreed what the chair is going to be focusing on, so that, which is an improvement from the previous approach. Yeah.
It's a good way of summarising as well, isn't it? The items. It's good to.
It's great.
And if we finish the agenda in time, but if any item today would be dropped or curtailed, it will be Darren's wonderful performance report, because validated, as he said, as he galloped through without drawing breath, a 140-page report in 3 minutes with no questions. The really valuable information is in the TI report. And something like the TI report, maybe with a couple of other things, that indicators that we choose, which is 10 pages instead of 140 would be. They'll always be there as resources, the performance report, but not necessarily to present. And, we dropped it from quality and safety, not dropped it, but it's there for noting, and people can ask questions about